So now I would like to, first of all, I would like to thank the organizers and Sajjan especially in particular for inviting me into this meeting. And I hope I can be of some use to all of you. In the next 10 to 15 minutes, I will be just going briefly over, especially what we can do as medical oncologists regarding the operable lung cancer. That's what has been given to me. The topic it may sound, but I feel I clarified with the organizers, I am going to speak on systemic therapy. So if you look at it, and the point is, most of the patients of lung cancer, irrespective of stage, do relapse. And most of the lung cancers, let's say in stage 1B also, you would have around 40% of them having a relapse, and it does grow as the stage grows. And around stage 3, the relapse rate can be as high as 70 to 80%. So this gives you an idea that we need something in the form of systemic therapy so that these patients can be achieving more cure rates. And that is why we need an approach which could be neoadjuvant or adjuvant. First, I'll go to neoadjuvant because this is a field that is growing very fast. The data is evolving, although it's not a standard, but the data, especially from the checkmate, looks very, very promising. And I'm pretty sure if one more data follows up with the same advantage, we would be speaking of neoadjuvant in operable lung cancers in a big way. So why neoadjuvant? Improved physical fitness and compliance is one thing why we need to look at neoadjuvant, because around 20 to 30% of patients post-surgery of lung cancer are not able to receive adjuvant chemotherapy, although they're eligible to do that because of post-op complications. Recovery is slow. They are not fit for receiving chemotherapy. Second is, you can also study the in vivo radiological and adaptive response of the tumor to systemic therapy, which is meaning like in a TNBC as we have done, or let's say in HER2 positive breast cancer, we do the neoadjuvant, we look at the PAT-CR. If the PAT-CR is not there, we try to change the protocol, add something else, like we add capecitabine or we add a TDM1 if they do not get the PAT-CR with the neoadjuvant therapy. So same, can it be done for lung cancer? Too early, but that is the way I think it is going to evolve. So if someone achieves the PAT-CR in lung cancer who has received a chemo and immuno, most of the times they will just receive probably adjuvant immuno. Chemotherapy can be taken away, but it's too early. But that's the way I think the world is progressing. Also, the opportunity to study the dynamics and the mechanism of anti-tumor response. That is something which I feel is very, very important, and this gives the advantage of neoadjuvant therapy. If you look at it, the neoadjuvant immunotherapy has been observed to facilitate the early development of the memory T cells. So what happens by this is they induce a strong adaptive anti-tumor response, and that probably is the advantage of patients, how they can be cured more even in the later part when there's a micrometastasis coming. These memory cells get activated, and this can take care of a possible relapse. And that is probably why people are so much interested in the neoadjuvant approach. The uniqueness again for lung cancer comes for the unique concept of lung cancer. We are not looking at PAT-CR alone. We are also looking at a major pathological response in lung CR. Anything equal to 10% or less of viable tumor cells would mean that the patients would more likely to do well post neoadjuvant therapy. If the patient has not achieved this amount of response, probably the patient is not going to do that well, and probably we have to modify our adjuvant treatment. So if you look at the neoadjuvant TKI, the trials are very, very small. Their numbers are small. You would not take any conclusive evidence from it. And usually the trials have given neoadjuvant TKI in the EGFR positive population for around 1.5 to 2 months pre-op. The largest data has come from the eMERGE CTONG 1103 study. And this is a study where they have screened 380 odd patients. 72 were enrolled to receive erlotinib, or that gave gemcitabine platinum, which probably in adenocarcinoma we would not be using it today. But at that point, we did use gem-carbo, and that was the randomization arm. And what happened for this was, and this was especially bulky patients, most of them had N2 nodes. If you look at it, 50% of this patient had multiple station N2 nodes. And the EGFR activity, the mutations were there in exon 21 in around 56%, and the 19 was around 16%. The response rate for neoadjuvant erlotinib versus the chemotherapy was more towards the erlotinib, but it was not statistically significant. And the PFS, although was significant, but it did not translate into survival advantage. This is the maximum we have of the neoadjuvant TKI. Major pathological response, what we told, less than 10% of the viable cells was observed in 10% of allotinib, while none achieved in the chemotherapy arm. So this is all we have the maximum data. So in neoadjuvant setting, TKI, no, till you have a very frail patient, not fit for chemo, and consent is well taken. If you look at immune checkpoint single agent, multiple trials, 1 cycle, 2 cycles, 3 cycles, you have across for Nivo, for Atizo, for Durva. And if you look at it, the major pathological response is around 20 to 40%. The pathological CR is around 5 to 10%. The response rate are not that huge. All of us know the median survival is normally not reached, and the complications are not typically which we cannot manage. Even there is a data, the NeoStar published last year for 3 cycles of nivolumab preoperatively versus 1 cycle Nivo and EP, and just 1 cycle, and look at the major path response, 21 versus 38 in towards favor of the IOI combination. Path CR 3 times more than 3 times in favor of the IOI combination. So is it the way we should do 1 cycle of just IO as a neoadjuvant and look at the amount of path CR we see? But the maximum data has come from this phase 3 trial. If you look at it, the nivolumab and chemotherapy versus chemotherapy once in 3 weeks, and this patient had eligible for chemotherapy at least stage 1B and beyond, 2-3A, did not have any driver mutation. They were randomized to Nivo and the chemotherapy for 3 cycles, and then they went for surgery after a break of 6 weeks, and there was an optional of adjuvant chemotherapy. These patients were 64 to 65, little bit on the elderly side. The squamous cell and histopathology and the non-squamous were half 50-50. You had stages more so of the stage 3A, and the PD-L1 was not evaluable for 7%, and lesser than 1 is around 44%. So 50% did not have a PD-L1 positivity. And look at what the trial showed. You did achieve the path CR, which was more in favor of the Nivo chemotherapy arm, 24% versus chemotherapy versus 2%. More of the patients on the combination arm did go on to receive lesser invasive surgeries. That is one more thing, that the patients did receive lesser invasive surgeries. The hospital stay was nothing much to talk about, so the combination arm was favored. But there are many questions unanswered. How many cycles are optimal? 1, 2, 3, we don't know. Can we combine with the CTLA-4? The NeoStar told yes, we can do 1 cycle is enough, but is it the last thing we are hearing? No. Do we need adjuvant chemotherapy? What regimen, what duration is still not known. And what about a PD-L1 status? Are these patients going to be treated as per the PD-L1 positive and negative? We also don't know. But as of now, we don't treat them. We treat them same irrespective of the PD-L1 status. Adjuvant, shifting gears to the last few slides. Adjuvant, if you look at it, we have been practicing chemotherapy adjuvant because of the 4 to 5% benefit which we get in this anyone beyond 4 centimeters size of tumor. And this is because of the LACE meta-analysis which is there. But one trial has to be told, the IM Power 010 on the adjuvant setting. These patients, again, 1B, 3A, this included the patients who had driver mutation. Adjuvant chemotherapy was given to 1 to 4 cycles, and then they were randomized to Atizo and best supportive care after surgery. And if you look at it, post-surgery, adjuvant 1 cycle of chemo to 4 cycles max, and then they were randomized to Atizo for 16 cycles versus best supportive care. And when they looked at the data, look at again the non-squamous is around 60 to 65%. The never smokers were around 20%. Stage 3 and stage 2 were the major patient chunk of this trial. And this patient, if you looked at PDL expressed patient, the hazards was 0.66, means 35% benefit for those who received adjuvant immune checkpoint inhibitors. But when you look at the right side, the EGFR mutation subgroup and the ALK, the benefit was not there. So we probably should not be giving this adjuvant immune checkpoint for the patient having this driver mutation. But irrespective of that, when we looked at all stages, because this included stage 1B to stage 3, and this was the 0.66, if you look, was only for this expression of PDL1. But if you look all patients, the benefit was still there, but the hazard shrunk from 0.66 to 0.79. Again, the benefit was maximum documented for anything having more than 50%. So if someone has the money, someone has the score of more than 50% of PDL1 and not having a driver mutation, that is the patient probably that will benefit from an adjuvant immune checkpoint. But beyond 1% also, the benefit is there. For EGFR mutation positive, all of us know the ADAURA is there, which has shown that there is a DFS benefit. All of us are looking for the OS benefit. The argument can go on, but this point, I think ADAURA has to be discussed with the patient. The right patient group has to be given this option. Duration, does it matter? Because everyone cannot afford the original osimertinib. Do this data of adjuvant gefitinib hold ground? It was significant for the PFS. OS was not beneficial, but here this graph tells me one thing: the patient who received gefitinib beyond 18 months did do much benefit than those who received less than 18 months. So osimertinib for 3 years, was it the key? And can we replace it with 3 years of gefitinib? I don't think so. The data is not there, but I think we Indian doctors, because of the cost issues, are going to discuss this. So the consensus which was published from the Chinese group told that preoperative use of neoadjuvant immune checkpoint with or without platinum can be given in resectable 1B, 2A non-small cell lung cancer. That's what they feel. But NCCN does not feel that way. Is there any molecular marker? At this point, no. How many to give? 2 to 4 cycles is recommended. Review every 2 cycles and then plan your surgery. The gap should be at least 1.5, 4 to 6 weeks. Some tell maybe 2 months, but not beyond that. For neoadjuvant immunotherapy in non-progressive patients, especially achieving PAT-CR, we still could give for 1 year of adjuvant immune checkpoint. NCCN now is advocating the adjuvant IM power 010 data, but the neoadjuvant is still not there in the NCCN. So to conclude, especially chemotherapy, all of us know, with immune checkpoint in the neoadjuvant might become a standard of care. We need probably more evidence for that. Something of a 2 or 3 trials duplicating the data. For the PD-L1 positive subgroup, stage 2, stage 3, adjuvant atezo and chemotherapy should be offered at least for mutation negative and more than 50% PD-L1 expression. I think it is now an important discussion point with the patient. Third, EGFR inhibitors in adjuvant setting, ADAURA has told us we can do that. So with that, I stop and I thank Sajjan, and I'll be open to any questions in the chat because I think the conference has to go on without delay. Thank you everyone for a patient listening.